The snack wasn't enough. Eh? Good afternoon once again. Great, thank you. So, welcome back for the second plenary. And to moderate this section is our own Dean of the School of Pharmacy and the person of Professor Kwame Ohini Boabeng. Shall we welcome with a round of applause as he takes charge of the second plenary?
Thank you very much, Mr. MC. We are already running late, but I think that we're going to have a very interesting and interactive section. So first, I want to find out if the following presenters are here. Please show by hand if you are here. Paul Obeng from University of Cape Coast. Is he here? Okay, thank you. Francis Agboke, Kintampo Health Research. Thank you. Thank you very much, Francis. Ruth Jokoto. Ruth, excellent. Edward Wilson, answer, UCC. Edward Wilson. Okay. And then finally, Isaac Nyako Kwache. Isaac. All right, so we're going to start with Francis. Francis is presenting on examining the relationship between maternal social demographic factors and adherence to the adoption of clean cooking stoves in the Kintampo district of Ghana. Shall we, with a round of applause, welcome Francis Agboke. Please, let's keep applauding until he gets here. Welcome. Can you please help me with the slide? Yeah, thank you very much. Good afternoon, Chair. Good afternoon, everyone. So I am Francis Agboke, presenting on behalf of the team that put together this work to examine the relationship between maternal social demographic factors and adherence to the adoption of clean cooking stoves in the Kintampo districts of Ghana. Thank you. Thank you, IT team. Yeah, so in spite of the advocacy and the push to have a good number of people shift from unclean sources of fuel
to meet their cooking and heating needs. We still have almost half of the world's population relying on biomass fuel and other unclean sources of fuel to meet their cooking needs. And as a result, this practice has actually predisposed a lot of people to health challenges that are related to household air pollution. And because we rely on these unclean sources, we tend to fell more trees, thereby destroying our environment and contributing significantly to the challenge that we are all facing as far as climate change is concerned and its harmful effects. It is in line with this that the UN has actually come up with the Sustainable Development Goals, specifically Goal 7, to ensure that we have a universal access to clean sources of fuel. So my team and I set out to assess the association between maternal socio-demographic characteristics and compliance to clean cook stove use in rural Ghana, specifically the Kintampo district. The study area has a population of almost 2,700 and 200,000 according to the 2021 Ghana National Housing and Population Census. The study area have people predominantly relying on unclean fuels, unclean cook stoves. That is the traditional tripod that we all know, and we can all attest to the attendant issues that comes with it. And because these fuel sources mostly come at no cost, they are seen to be good for them because generally the people are poor. So this is actually a cluster randomized intervention trial that we conducted. We randomized communities in the study area into two intervention arms. One, a BioLite arm, which is actually an improved biomass fuel cooking stove that emits less smoke compared to the traditional tripod. And then we also had the second intervention arm being the liquefied petroleum gas cook stove arm. So we actually recruited pregnant women who were identified in their communities by trained field workers and put into these intervention arms. For the BioLite arm, we had 519 women, and then for the LPG, we had 357 women. Each of the arms, each participant was given 2 BioLite fuel cooking stoves and then 2 LPG cooking stoves. Those in the LPG arm were supplied LPG free of charge throughout the duration of the study. So the picture on your right, which is my left, is actually the one we are all familiar with, the tripod. And then the one in the middle is the BioLite. It also uses fuel wood, but then emits less smoke. You can see the environment, and then the LPG arm as well. So the women were also given 2 cook stoves for the LPG. This study was actually part of the Ghana randomized air pollution and health study, which assessed whether clean cook stoves improve both birth weight and then reduce risk of pneumonia among infants. The data we collected was quantitative data on the use of clean cook stove and how often they were used. Participants were asked how many times they used their cook stove over a week to determine their level of compliance. We analyzed our data descriptively. Questionnaire data was summarized as proportions and then percentages. Our results. So, by way of demographics, we see a lot more of participants being farmers as far as their occupation is concerned. And then for those who were uneducated, the majority obviously were uneducated. By way of their age, this is the distribution. And then for compliance, we found that as far as ethnicity is concerned, some ethnic groups were more compliant to the use of the adoption of clean cook stoves than others. And then for maternal age, we realized that it was not significant as well. Education, occupation, and then household size did not really have any impact in determining the use of clean cook stove. So age and ethnicity were found to be associated with the use of clean cook stove. And however, education and then occupation were not significantly associated with the uptake of clean cook stove in the area. We propose that further studies be conducted to actually find out why education doesn't seem to have any impact on the adoption of clean cook stoves. And then we will also want to find out why occupation doesn't have any impact as well. So these will be our recommendations, that further studies be conducted to further investigate this, and then we see the way forward. We will want to acknowledge the Kintampo Health Research Center of the Research Development Division of the Ghana Health Service, the National Institutes of Environmental Health Sciences, which provided the funding, and then the study participants who volunteered and gave us very useful information. We will also want to thank the organizers of this conference for giving us the opportunity to present our work. Thank you very much.
Thank you very much, Francis. Since we seem to have some time, even though we started, quite late, we seem to have some time because 3 of our presenters did not show up. And I must say, this is a section on environmental and climate change. Francis has set the tone very well, talking about adoption of clean cooking stoves in the Kintampo district. I'm sure you have some questions for him. So we're going to open up for discussion because, as I said, we seem to, have some time. So maybe the first question that I'll probably, draw the first blood. Very interesting piece of work, quite interesting. But I want to find out to what extent are people still using the traditional way, what they call it, in the district? Is it still something which is done, or people have actually shifted? For that matter, you actually look at the BioLite and then the LPG. I thought you were going to also compare, and tell us about those who are still using the traditional way, which our forefathers used, which you said is the most unclear.
Okay, thank you very much, Prof. So for those using the traditional cook stoves, they were actually treated as our control arm. So we didn't factor them into this particular analysis. We were more interested in the intervention arms, which has to do with the introduction of these cleaner cook stoves. Yes, people are still using the tray stone because from the literature, about 23 million of Ghanaians are still relying on the use of these tray stones. And for a population of just about 30 million, and we have that colossal number still relying on the tray stones for their cooking needs, that should be worrying.
Thank you very much. And I think you already identified that there are some public health issues associated with the use of the traditional. So maybe some more education, should be done, and some dissemination also of your findings. Thank you very much. Okay, so now maybe I'll take first 3. Okay, so there's a hand at the back. 1 second. Good. The third one. 3. Okay, so we'll take the 3, and then you respond.
Thank you very much, Mr. Francis, for this interesting topic attended to. Please, I want to find out from you if in your finding you were able to explore from the participant their view of depending on the traditional way of using the cooking method, the clean cooking pot that you said.
Yes, so not specifically.
I want you to hang on.
Okay.
So note the questions, all right, so that we can make efficient use of the time.
Okay.
Note the questions, and then after that you respond to it. Okay.
Thank you very much. Mine is on your sample. You said you had trained field workers who identified the mothers. How were they identified?
So note that one as well.
Yeah, I'm not talking.
All right. I hope you remember the first one.
Sure.
There's a third hand here. The third hand, so that he can respond to all the questions. There's a hand here. We'll allow for another round of questions.
Okay, please, my question is, I want to know the exclusion and the inclusion criteria for the selection of the pregnant women. And also, I want to know if this being an intervention trial, were they followed up for a period of time before they got the results? Thank you.
Okay, thank you very much. So to the first question, yes, not for this particular study, but we carried out another study to qualitatively look at why people are still using the three cook stoves. And some of the findings will interest you. Some are of the view that, well, meals prepared on these intervention cook stoves do not taste the same as the ones prepared on the three cook stoves. And then some are also of the view that, well, for certain types of meals they prepare, these intervention stoves are unable to support that cooking practice. Thank you. Then for the next one, how were participants selected by full staff for the study? So we, as I indicated earlier, we randomized these communities into three arms, but we control intervention 1, intervention 2. And then, because these people are all in our database, to qualify, you have to have taken seed. So pregnant women were enrolled for the mother study, okay? And as soon as they get pregnant, we get notified, and then they are recruited onto the study, depending on which arm they find themselves. So it wasn't left to the field worker to go and determine who to select and who not to select. Then, yeah, so I think I've
You've answered it.
yes.
Right, that's fine. Thank you very much. I'm sure you are happy. Or are there any follow-up questions? All right. Follow-up? Follow-up? So he didn't answer your question exactly. The inclusion and exclusion.
Okay, so for the inclusion criteria, you should have been a resident in the study area for a minimum of 3 months. You should have taken seed or be pregnant, and then you should, I think these two are fine for now. And then you should have been recruited or identified by the mother study. Thank you.
All right, it's getting interesting. I mean, the first one was how the people would want to cook the akpele and this thing on the traditional. All right, so now next round of questions. I saw a hand. All right, so one, any other? Oh, wow, it's getting interesting. Okay, so we'll take 4 then. 1, 2, 3, 4, 5. We'll take 4. All right, so he can respond. And then we'll allow for the next section. Okay.
Thank you very much, Francis, for this wonderful presentation. I just have some simple questions to find out. Your discussion or conclusion, you were just hitting on occupation and education not significant. You are talking about it, and you said there should be further studies to find why it is not significant. So why do you want to do studies to find out why it's not significant? Then you didn't also add socioeconomic status, because most often these things are linked to that. Can you give reasons why you didn't add that? Because important variable. Thank you.
Hello, please. My question is on.
Hang on. Maybe to make the section interesting, kindly introduce yourself first, and then you ask.
Hello, my name is Aisha Fadila Adamu, and my question is about the part he said that when the woman gets pregnant, they are notified and they are enrolled. You know, I was thinking if you are doing an intervention study, you have a baseline, and then you have an end line when everything stops. I didn't know along the way you could be recruiting people into the intervention as well. I want to know if that is something that is done, or it was just in his study that they did that.
Okay. My name is Samuel Busoka. Please, my question is on the... okay. Okay. My name is Samuel Busoka. I'm with the Ghana Health Service, Volta Regional Health Directorate. Thank you. So my question is on your recommendations. You made, in your findings, you said age and ethnicity were associated with your outcome, but you didn't highlight which particular ethnic group was actually associated. And I thought maybe in your recommendation you would have made that clear, but that was not done. Then you didn't also tell us which statistical test was carried out, because we don't know your outcome variable. Was it continuous or categorical? So based on that, what kind of statistical analysis was done? Thank you.
Okay, so my name is Chelsea from School of Public Health. So you mentioned in your introduction that people in your study area, UHAS, sorry. So you mentioned in your introduction that the people in your study area are poor. That's why they use the method of cooking that the method of cooking they have before you came in with your intervention. I'd like to find out, did you take the trouble to find out why they prefer to use that method? Or you just assumed that they are poor, that's why they chose that particular method of cooking?
Maybe let me intervene on this last one. You see, the second part of the study was focused on the intervention. So what he presented was on the intervention. Yeah, he just mentioned the traditional way in his introduction, but it was not part of the study. All right. Unless you have an answer to that.
Yeah, thank you, Prof, for the intervention. Except to add that, except to add that poverty bit I mentioned was not only restricted or exclusively to the people of the Kintampo area, but generally, as I indicated, 23 million people. That's food for thought. But surprisingly, I also indicated that occupation did not really have any bearing on the decision to either use or not to use clean cook stove. Thank you. Okay. Yeah, for Dr. Adaba, math, occupation, education, yes. So these are quantitative things that we actually went and then got. So as a social scientist, I will be more interested in wanting to know why these things are acting or causing people to behave the way they are doing. I will expect that a highly educated person should actually appreciate the need to want to use a cleaner method of cooking. Yeah, exactly. So I will now, since this is happening, I will now want to rather go and ask, why are you not using it? Rather than sit down and assume that no, an educated person should know better and adopt these kind of interventions that are introduced. And then we had one on baseline. Yes, we actually, prior to the start of the parent study, the Ghana randomized air pollution and health study that I alluded to, a baseline data was actually collected before the intervention was rolled out. I don't know if that answers the question. And then the other one on ethnicity, why I did not indicate which specific ethnic groups. Yeah, so we did that intentionally because we didn't want to put out actual names there to stir up controversy here as to, we don't really know who is covering this, where this information will go to, and then we may end up being misquoted. I will not be there to explain to wherever this misinformation will get to that, hey, they said Gan people don't like using, or if I'm an if, that's why I'm using myself. Don't like using clean cook stoves. So this one was done on purpose. Thank you very much. Then the statistical method. Was this categorical or?
What informed your, what type of statistical method did you use? What type of data? Were there continuous variables, categorical variables? But it looks like yours was more of a qualitative.
No, this particular version was quantitative.
You don't remember?
Let me hire a lawyer to bail me out.
You're allowed to do so. You're allowed to do so. Any other member of the study team here who wants to respond to that question?
Dr. Asaya Ayengebise. Oh, Dr. Asante.
Right, yes.
Thank you very much. The slides were shown. One of the slides showed the variables that were used. And if you can just scroll to that one. So in terms of the, some of them, it was categorical variables, and they were basically logistic regressions and things like that. And they were not presented as they are. So yes, so here they are. So education was put in there. Education was put in as a continuous variable. Occupation, same categorical variable. Household size was also a continuous variable. But let me speak about the ethnicity whilst I have the mic. I think somebody asked about why we didn't use the names. In addition to what Francis just said, I mean, now use of or disclosing ethnicity is also becoming sort of a personal identifier. So we usually would not want to include that. But usually we ask ourselves, if we know that it is ethnicity A and then ethnicity B, would you give them cook stoves or cleaners tools and leave ethnicity C? I mean, so in interpreting the data, we'd like to not to show this for the outcome of interest. But if, say, we're looking at something like some hypertension or diabetes or something that has some genetic factors, probably want to show it, but I am at the right audience. Thank you.
Thank you very much. Really, very, very good. I think there was also one on the design, all right? You know, that has not been answered. The lady, your question, isn't it? Oh, yes, is it answered? You're okay. Fantastic. Thank you very much. For the sake of time, let's give a round of applause to Francis.
Thank you.
I think he's very interesting study. Very interesting. So now we'll move on to the next session. We just want to remind ourselves that the session is still on environmental and climate change. So we want to invite Ruth Jokoto of the University of Health and Allied Sciences. Ruth is talking about change and flooding disaster nexus, implications on WASH and mental health in Fuveme, Agokeji. I hope I got it right. Thank you very much. A round of applause, to
I'll stand on all existing protocols. Good afternoon. Good afternoon. Thank you. I'm Ruth Jokoto, as earlier on mentioned, and so I'm a former student of the Fred N. Binker School of Public Health, UHAS, and that's in Hawaii campus. I'm also the founder and director of Green Dialogue Africa, which is into climate change advocacy. So yeah, I'm presenting on the nexus between. Okay, sorry. The nexus between climate disasters and wash in Fubeme, Agokeji, in the Keta district of the Volta region of Ghana. And I did it in collaboration with Messiamo Paintel, and this was part of the fulfillment of our continuous undergraduate program in environmental health. Yeah. So this is what my presentation will be focusing on. I'll try to be on time as much as possible. And I think when we listen to the news of late, we've been hearing a lot about climate change and its effect, its impact. We are hearing more in the news and the media. But when you go online to the research centers, the research hubs, you hardly find documents stating a lot on what is actually happening in the areas where this effect is happening. So we took the liberty to study into the effect of climate change and its impact on water, sanitation, and hygiene, and the effect is also having on the mental health of the people that are suffering this impact, most precisely the coastal areas. And the climate change has become a global public health concern and is currently driven by the human-induced greenhouse gases. Formerly, climate change, or maybe, let me say, centuries ago, climate change is supposed to be a natural phenomenon. But human activities are making it more enormous. And we are having its impact now. When it has to rain, it doesn't rain. When it doesn't have to rain, that is when you have more of rain. And this leads to a lot of issues on grounds. Globally, this has triggered a lot of environmental effects, including melting of glaciers, glacier shrinkage, altered ecosystems, and so on. The vulnerable groups, particularly as the low and middle income countries, which Ghana happens to be one. When you look at statistics from the UNFCCC, we realize that Africa contributes less as 4% to climate change, but yet we are suffering the most from it. So why did we decide to do this study? What is the rationale behind the study? We had few information about this incident, like I stated earlier on. And then most of the information is available to also explore quantitative approach, which we think didn't get more of the specificity of the problem. So we decided to get more of the issue on hand. So we did a qualitative study to be sure of, to be exact about what is happening on grounds. And then specific vulnerable groups in this vulnerable community in South Volta, which has suffered flooding incidents previously and are barely targeted for scientific research. When you look at a community like Fuveme Agokeji, from our studies, we realized that a lot of people were not going there. I am personally from the Volta region, that side of the country, so I know what was happening on grounds. And hence the need, and that was the reason why we delve into this topic. What was our objectives for this project? To explore the nexus between the climate disasters and WASH. And then to achieve these objectives, we had our specific objective as to explore the events on water use and its availability on this community. What is the quality and the quantity of water available to the people? And then to explore the effect of this flooding event on the sanitation and hygiene practices of the community. And we also looked at the mental health implication of this incident. The study area is a small island at the outskirts of the Volta region in the Keta, from when, I don't know if any of us are familiar with the area, but it is located on the stretch of the Anyangwi River banks, and the community is an island situated in between the sea and the river. We employed a cross-sectional survey design using the qualitative data method. We used the structured interview guides, and then we had specific teams, but we had sub-teams generated from the answers that were given. So our sub-teams were generated from the answers that the participants provided. So we used a purposive sampling for our participants. Yeah, so the inclusion and exclusion criteria. The study included individuals above the age of 18 years and were physically available and fit to participate in the study. And then we excluded people that were under the age of 18 years and people that were mentally challenged and were not fit to respond to our questions. We targeted stakeholders like the household heads and then heads of school in the community. Before then, we had already issued an ethical clearance. We had already sought for ethical clearance. And then our key findings, the impact of climate disaster on water quality and quantity. When we delve into this search, we realized that from our findings, there was seawater intrusion that was affecting the water availability and quality. So what happens is that when the flooding incident, the coastal erosion happens like that, the seawater intrude into the wells, hand-dug wells that were already being used by the people. So they are not able to use the water again because it becomes very saline, salty. And some individuals lay pipelines for the community, but the coastal erosion has still eroded some of the pipelines, leaving a minimal amount of it, like 2 or 3 to just serve the whole community. And the inability to afford this water has rendered some households to still go back to the dams that are already salty or saline, and then, or they go to the river banks to fetch water. Bear in mind, this community does open defecation, so if they go to their riverside and they defecate there, some households also go back there to fetch this water to drink. And when we look at the effect on the sanitation and hygiene, their toilet facility, I had an old woman who permitted me to use her name everywhere I go, but I won't use it. So she told me that she has been born since the 1940s, and she has seen once in the community that toilet facility was constructed, just once, and this was somewhere in the 80s. And so the whole community for these years haven't used public toilet facility in the town, except for the school. Even the school's own has been washed by this coastal storm. I wish I had added pictures, but next time. And there is also a prevalence of the water-associated disease, like I mentioned earlier on, when they go to use fetch this water from the river banks while doing open defecation. And when the temperature rises, there is a lot of, and the sea comes, while it's going, there is a lot of lice, and there is also a lot of mosquito breeding grounds, which leads to the malaria infection. Key finding number 3, the influence of wash inaccessibility on the mental health of the people. The people reported that they suffered depression, overthinking, sadness, and trauma. Some also experienced anxiety. At the formation of the cloud for it to rain, they start thinking, they start having anxiety because they know if it rains heavily, they are going to be in trouble. So they start having anxiety. And one also said, if you can be there at night, midnight, and the sea is at your doorstep. There has been a case where they had a fatality, and the person died of heart attack because the sea just came at once without notice. And there was inadequate coping mechanism. When we asked how they seek help when this depression and stress or anxiety happens, they told us that some of the self-comfort, they only tell themselves, it's okay. I mean, it's something that has been happening and nobody is there to help us, so why worry about it when nobody will even mind you? So these are situations that are on grounds. There are no coping mechanisms except for self-comfort. This is what someone said, and I would like to read it out. He said, when you look at the building, talking of their coconut leaves weaved for buildings, in which I am in now, that is not what I wish to be in, and it implies to everyone in this community. We built with cement blocks, and the sea has succeeded in destroying them when it happens like that. When it happens like that, it worries our minds a lot. We think a lot, and every day this makes us become depressed. You know, it is not easy seeing what you worked for many years destroyed like that. And this was from a male of 44 years, who is a fisherman. And a civil servant of 37 years said, a lot happens mentally, like people become depressed and sad every day. And this person is just a visitor to the community, and he has also experienced this effect. So, to our discussion, we emphasize, HIPAA et al. 2019 emphasized that climate change, including sea level rise, can lead to seawater intrusion into freshwater sources, rendering them unusable, which is consistent with the contamination of wells and boreholes. A study by Gage and Banerjee 2021 highlighted the link between climate change-induced environmental changes, such as flooding and the increased prevalence of vector-borne diseases like malaria, echoing the public health risk described in the study. Addressing the mental health impact of climate change is as critical as addressing its physical effect. Interventions should include counseling services, community-based mental health programs. And in conclusion, climate disasters have had impact on water, sanitation and hygiene, inaccessibility, and mental health of the people of Fuveme Agokeji community. We are recommending that climate resilient and sustainable sanitation facilities such as toilet and urinal affected communities to be built to prevent open defecation. We are also entreating local authorities to collaborate with the environmental organizations and the environmental health departments and NGOs to provide hand washing facilities in affected communities. We are also entreating the Ghana Health Service to design emergency programs that provide psychological support and alternative livelihood options to flood victims and those affected by the impact of climate disasters. The government of Ghana, together with other relevant stakeholders, should take emergency measures to address climate change by adopting green economic measures to reduce over-reliance on fossil fuel. Thank you.
I think we can do it better for Ruth. Thank you very much, Ruth. Very interesting, stimulating presentation on climate change and flooding disaster nexus, implications on WASH and mental health in the study area, Fuveme Agokeji area. Thank you very much. So we are opening up for discussion. And maybe, as usual, I would like, quite interesting. So what have you done for the community after the study? I mean, have you taken anything back? There are a lot of mental health issues that you identified. So what have you done for the community?
So this was a collaborative work. I was actually not looking, personally, I was not looking into the mental health aspect. It was brought on by a colleague who is not here. So I was personally interested in the sanitation aspect, owing to the fact that I'm an environmentalist. So water and sanitation aspect. So my organization was listed as part of implementing organizing body to intervene, write proposals and seek for funding to rebuild some sanitary facilities for the community, which is in the pipeline. Yeah.
Thank you very much. As a follow-up, okay, Prof. So as usual, we'll take, the hands are many. Okay, let me see the hands. How many? Okay, we'll take 2 sets of questions. All right, we'll take first 4 and then the last 2. So we'll give Prof. Oh, interesting. Okay, I think let's give it a round of applause. If you give a presentation and it generates that discussion, it means a very, very interesting work. So we have some time. All right, we'll take all of that. So we'll take the first 4 and then we'll take it from there. Then you answer. So kindly note.
Chair, thanks very much. I rose up to ask the question because I need to step out very briefly. But, that's very interesting. I was expecting that the situation you described, the lady who said since the 80s there hasn't been facilities, I was expecting that on the doors of the local authorities. You mentioned local authorities. You've worked in UHAS. You know the regional health directorate. You know the political wings. Did you really knock? I'm not saying, I'm using the plural you.
Yes.
The investigators who found this resource. Did you really knock at the doors? You are looking for funding to help solve the problem. I don't think that is the way forward.
Thank you very much. So I'll look here.
So I'll be walking out. You can answer to the
Okay, so let me answer.
So she wants to answer quickly. All right. Okay, so just note it. So yes, Prof.
Yes, thank you so much. All protocols duly observed. That was a nice presentation. I apologize for the first speaker. I came a little bit late. Well, the number one thing I wanted to say, Professor Hui has already mentioned it, is that what is your take back? What is your give back to the community? And I think the only way is for you to actually make sure that it doesn't end on the shelf, but you link community. And then the second one is, I want to call it a note of warning. Well, this kind of presentation or this kind of paper that we emanate may likely be in a Ghana paper, probably in a low impact paper, because it's related to the issues of Ghana, particularly Keta. So please, as you are working on that, try to also work on paper that will make it to be a flyer. Otherwise, there will be no depression. I hope you are not going to become a victim of what you have just studied. Thank you.
Thank you very much. And I would also advise that you do a very good policy brief, all right? And share with the powers that be. So, yes. Let's give the opportunity to a lady, gender balance. And after that, there's a microphone here. So, Sam, we'll come back to you.
Thank you for this very interesting presentation. Great work. My name is Maria Ivankovic. I'm from McGill University, Canada. I have two questions for you. First one is to ask about design and why you didn't include adolescent population, why the cut was 18 years, as some of the work that was done in adolescence in the areas where there are emergencies is showing high anxiety in that group. And also, since I'm not sure in that region, but in Ghana is present adolescent, a lot of adolescent moms. So I'm wondering, that in that you are not capturing that population that might have a really big impact on mental health and on WASH. So that's a first question. And the second one is related to authorities and your observation, basically, when you went to conduct study, if you noticed any practice in place regarding certain strategies for, like in the case of emergencies, if Ghana Health Service has certain practices or if they're ready, if they have preparedness for this type of emergencies such as flooding, and could your work inform such of those actions? Thank you.
All right, so last one.
Thank you very much. Ruth, that was a very wonderful presentation. My name is Jeremiah from the Food and Drugs Authority. With respect to, when you were talking, you said that you come from the area, and I want to know how you manage any form of bias in terms of the principal investigator, if you are biased or whatever, yeah, because you come from the area and the attempts to design the study in a way to not to get actual whatever can be very important. Thank you.
Thank you very much, except that I actually didn't see that at all, but you would answer. Okay, so can you?
Okay, so I'll start by answering first on. Did you really knock on the doors of the political people, the health directorate, and all that? So, as an organization, I mentioned earlier on that I run an organization. So we are into seeking for that help from these people. And we are on it. We are actually on it. So yeah, we will definitely get back to the people. And Prof also mentioned that I put it in paper review. Well noted. The suggestion is well noted, and I'm grateful for that. And also mentioned that I do a policy brief, also well noted. Now, on the design on why I didn't include the under 18, I had earlier mentioned in my presentation that we included people that had suffered consequent impact to the current. So we're looking at baseline and then comparing more of a comparison data. So we are looking at those that have had the impact, those that have moved from places to places and now at one place. So we were of the view that the under 18 people didn't have more knowledge about the incidents. So that is why we didn't include them. And then if Ghana Health Service has measures in place already, or if the projects will inform those decisions. So ours was to develop this and then subsequently follow up to seek for this help from these people, because before something can be done, someone must take a first step. So this is the first step we have taken. We've always heard it in the news, but has there been literature to back this up? So this is the literature we have gathered. And from what we realized, there hasn't been any coping measures or any strategies in place. It has always been promises. So maybe the organizations or the health services are looking for scientific data. So we have provided them with one. So, yeah. And if there was no bias, not at all, I will give reasons. So I am from there, but I was all my life raised at the western part. So I'm from Keta, yes. So Jita to Puvema is like a walking kind of, you just have to take a canoe to that side. So, not precisely from the community Fuveme, but I am from its environs. I don't know if you get me. So there was no bias. And the people that joined me to do this research, some are from, well, one person is from Ashanti region, so there is no way there was going to be a bias, you know, the Ewe tree relation.
Thank you, Ruth. And I think even if it's from there, if there's a problem there, you want to get scientific information to find a solution to it. So again, I don't think, from the lens that I'm wearing, I don't see bias at all. Thank you very much. So we'll take the last round. Unfortunately, we can only take 4 questions. So Samuel Afari, wow. Now this is tough. Prof. Margaret, what do I do? Okay, so 1, 2, 3, then keep it the last one. Thank you very much. Unfortunately, time is not on our side, but I think the discussions can continue, you know. Yes, thank you. Okay.
I'm Eugene Dadoy, a consultant psychiatrist with UHAS, and I think I must commend the work, but I had a few challenges. One of them is we didn't get of the place to show that when caused by the climate change, meaning there should have been a history to tell us that, okay, yeah, this area was not experiencing flood until we started getting message when it started. So I didn't get that picture. And you said it is an island, which we're talking about rivers. I'm not too sure whether you are talking about the Volta River forming those islands and whether this is close to the shore, saying that we have brackish water there and the effects of it. That didn't come out clear. I'm a mental health expert, and I don't think it is appropriate to just say because somebody say I'm depressed, meaning that they have a depression. So that is a very, serious thing we can't do in a study, because the word depressed is an English word that can mean you just feel down. It doesn't mean you have a clinical depression. So you go out and say that people have, so I was going to ask how you measured that, but it was from the last slide that showed that was what they said. So eventually, probably you are equating what people say as symptoms to be a disorder or a challenge, which is not the best. So I think we should probably get the linkage to the problem.
Thank you. I also think this is a very interesting presentation. But then considering the fact that you are being encouraged to do papers and also do policy briefs and about this, I want to touch a little bit on the methods. Yeah. So I noticed you were talking about a cross-sectional survey where you did purposive selection of respondents and you also did qualitative interviews. I think these terminologies are quite conflicting and they do not belong to one same research mix. So when you talk about a cross-sectional survey, then it's purely qualitative, where you are looking to do simple random sampling and give equal opportunity to every member of the population to be included in the study. So I'm only trying to, it's not for you to respond to this now, but then re-look at it again so that you can put the right words into the right context so that it doesn't give so much questions about your methods. Then the other one I want to talk about is, I noticed in the presentation of your results, you gave a lot of bullet points and you were speaking to them. Already qualitative research is a little bit challenged when it comes to rigor, and if people really believed what is emerging is coming from the data. And so though you have transcripts and you are unable to present all the quotes here, you would want to always have some small amount of text from the respondents to substantiate your findings, so that it takes away the question of where are all these coming from, because we have to know that it's emerging brightly from the data and it's really rooted in what you got from the respondent. So just a few words about this so that in presenting your findings, you are quite careful about how you put these things. Yeah, thank you.
Very much. So we want, no, there's a hand here. We really want short questions so that we can have short answers. Right? Can we limit the introduction around the question?
Thank you very much, Madam Ruth, for the good presentation. My question, I think, was touched briefly by someone, but I still want to find out. So, what assessment tool did you actually use to assess the depression and trauma? And if you have used that, it will be good you share with us. And then my next question was on your recommendation. And when you started, you said the community is a small island community. And with some of your recommendation was to build public toilet for this community. And I want to maybe talk on this, that can you reassess the community if they could be relocated? Because recently in my area, Central Town, with the artificial flooding that took place, most of the communities were immersed completely in water. With this public toilet wholly immersed in the water, you can see the contamination further. So we have to look further into the future and not a temporary solution of just building a public toilet for the community. So that's just my point. Thank you very much. My name is Dinah. Sorry for not.
Hello. Hello. Right. Thank you very much. Very nice presentation, and I feel the passion. I also got asked when I submitted a paper a few weeks ago to show that I am not biased because I'm from Ghana, and this was about malaria, and my answer was that we are scientists that we are working, and I'm sharing that answer with you, okay, which you can also use. Okay. I mean, we are bound by some ethical standards to be able to report what we see and without bias. And then it's a positive thing to actually be from an endemic area or a local area for you to identify something to do. And so just sharing that with you. But in terms of the coping mechanisms, I think one of the key things that can easily be done as soon as possible is to sit with the community to prioritize the coping mechanisms into what can be done immediately without any resources. I can assure you that some resources will not come soon. And so there are certain things that can easily be done so that they can live. But ultimately, maybe resettlement is one of the things they have to look at. Thank you.
All right, so we'll give you the last opportunity.
Thank you. My name is Frank Obin, School of Medicine. Thank you for a wonderful presentation, qualitative study. A lot of people run away from it. Well done. As one of my bosses said here, the cross-sectional study is for quantitative studies, so please note that. I would be grateful if you can let us know the saturation point of your study and therefore the sample size. And then the last one to Dr. Dodoy, concerning the depression, instead of her going to do a whole lot of data collection again, can she change the language from depression to, say, they feel down or they felt sad? Thank you very much.
Thank you very much. That was also going to be my comment, because I think she described what the people meant by being depressed exactly. So, Ruth, I think you can take these sort of questions. But again, once again, let me commend you. You cannot have any perfect study. Study may have shortfalls and all of that, and that will be acknowledged in your write-up. So I think this is good. We'll still encourage you to, put in.
Please, this is my undergraduate thesis. It is not a professional research, please. Thank you. Okay, so that was just by the way. We are improving. With comments from you, I believe will be there. So no geographical area, specific geographical area. I had earlier on mentioned that I wish I had put some pictures and maps on the presentation, but time didn't allow me to do that. So I don't know if I can directly send you a link to the community, to the person that asked the question. Is he a yes? Okay. And then the depression, so I have noted it. I'll just change the language. Thank you so much, Doc. So stress or feeling down, sure. Okay, so stress is better. Anxiety? Okay. Yeah. All right, thank you. And with the cross-sectional, with the coping, I think I mentioned that we did qualitative study and the quantitative for coping mechanism. The coping mechanisms, we had a list that we take for the people. But then I've also taken note of that. We'll work on it. I beg you. Okay, so the relocation of the people. These are people who are not ready to be relocated because they feel that is where their livelihood is. That's where they get their source of income. So within our questions, we have all this side questions for them. So the questions they answer, we have sub-themes that we ask them through the questions they answer, and then they were really not willing to be moved because they are, from them, they are tired. This is their sixth place that they are moving to. So right now, they are not ready to move. So the best they can do to them is provide alternative livelihood for them when this happens, and see to it that these problems, their needs are met. So yeah, that's it for the relocation of the people. And the suggestion on the bias and the coping mechanism is also well noted. So the saturation point, we looked at, we got saturated data when, hello, please, you asked the question on saturation. Please listen. Please, the saturation, when this, we realized that the last 8 people were given the same answer. So there was absolutely no difference, as if they were sat down and were taught what to answer. So that was when we realized that we had to end the interview. That was 28 people. Yes. So thank you so much. It was nice having you.
Thank you very much once again, Ruth. Let's do it better for her. Well done. I think the issue about relocation, the recommendation is if it can be reassessed, Ruth, if you could reassess, because this is something that was coming kind of perennial. So if that could be an option, and there may be ways of talking to them to see if they can be relocated. Because, and on that note, thank you very much. I hand over to the MC. Thank you.
That was a very interesting one. And coming from the area that can relate. So it's a very serious issue down south. And Ruth, I'll lend you my support in knocking the doors. So this brings us to the end of the second plenary. And we will go for lunch from here. After lunch, we're going to have the breakout sessions. The breakout sessions will be moderated by Professor KP Asante. He will be leading the group that will be at the IAC. That is so we'll show you when you were going out, not far from where we had the snack. On the left, the structure on the left of where we had the snack, it's where we have the, yes, sir. Yes, sir. So that's where the council chamber is, the top of it, of the council chamber. You have the IAC. There will be another session, another group will be at the council chamber, and that will be moderated by Professor Paul Amuna. And the third concurrent session will be at the IAC conference room. So there are two, the IAC training room, and there is a conference room. All at the top, they're very well labeled. So once you get there, you'll be ushered in that you can, and then go for the various sessions. So the moderators, once again, Professor KP Asante, the director of Kintapo Health Research Center. He will be leading the first concurrent session on health partnership and nutrition. The second concurrent section on non-communicable diseases will be at the council chamber, and the third concurrent section will be at the IAC conference room. So these are the breakout sessions we have in after lunch. The breakout sessions will start at 2. We're supposed to start that at 2. So we hope we would all do according to time and start those sessions early so we can close early. Because we've spent some time here, the 2 may not be convenient. And so 2:30. So the sessions will start at 2:30. And so thank you. We're breaking now for lunch. We would resume the breakout sessions at 2:30. Thank you. I think we can give a round of applause to ourselves and the presenters. Akpe. So we are going back to where we had snack for lunch. Thank you.